Okay, let's kick off. Welcome everyone to this session looking at interpreting data. So looking at that tension between causality and correlation and making that decision to respond in outbreaks and public health emergencies. Firstly, we're going to have Mark Guilthorpe from Leeds Beckett University talking to us about prediction versus causal inference. Over to you, Mark.
Okay, so thank you very much for inviting me. Just check that you can see my screen.
Yeah.
Cool. Okay, so yes, I hope I can do it justice in the 10 minutes. So we'll see how it goes. But yeah, so I'm going to talk about this aspect of data science that I think causes quite a few issues sometimes. To advance my screen, but it's not working. It's interesting. Maybe I've shared the wrong screen. I'm sharing again. Good old pilot error here for you.
No problem.
Now then, is that advance? Yes. Okay. So in the context of what the network does, I'm interested in how it views the necessary response of using data and analytics against the three pillars of data science, which I think are fairly self-explanatory. Description is often very, very informative, especially large and complex data, but doesn't involve perhaps any analytics. But prediction and causal inference, I think, do get conflated. So I'm going to focus on the issues of that. So the question I would ask is, what are your objectives? Is it to predict future events, to prepare for these events? That's not changing them, that's actually just preparing, whether it's a resource issue, workload, or challenge to prepare, opposed to understanding the cause and effect with a view to intervene, therefore to prevent certain events. Because they may seem very similar, but they're actually fundamentally different. Because causal inference requires that we identify and estimate counterfactuals, things that haven't happened, which you can't actually learn from the data alone. Because if you think about how the data is seen, it's actually all just a mass of explanatory variables or predictors. But when we try and do causal inference, we have to bring external knowledge to bear that tells us something about the data generating process that led to the observations that you're working with. And it's that extra information that's critical. Predictive modeling, therefore, will ask what's correlated with the outcome, what's a predictor of associated with the outcome. And whilst that does appear to focus on individual covariates, it's actually the joint information of all of the covariates that leads to the optimal prediction model. In a causal model, however, you're interested in the total causal effect of a particular variable on the outcome. So it's effect focused and specifically variable effect focused. So if we look at the differences between the two, the aim of predictive modeling is to just determine the outcome. It uses the covariates, but the focus is the outcome. Whereas in a causal model, the aim is to estimate a causal effect of a specific covariate. So the focus is the covariate. In predictive modeling, we're interested in maximizing the outcome variance to be explained by the covariates. In causal modeling, it's the accuracy of the causal estimate that we're seeking for a specific covariate. So distinctly different. And this affects the selection issue of covariates. So in predictive modeling, you want to balance the precision of the outcome that you're trying to determine with model parsimony. So you're trying to reduce or distill down the number of covariates needed to do that. With causal inference, however, it's the external knowledge and judgment that you've tried to bring to the problem that will determine your covariates. In predictive modeling, it's just the availability of covariates that you start with before you distill them down to be more parsimonious a model. In causal inference, you have a specific interest in the role of those covariates in order to actually focus on that specific causal effect that you're after. So in prediction modeling, the exercise is about maximizing the joint covariate information. So it's utilizing what subset of variables you have to explain the outcome or predict the outcome. In causal inference, you're interested in that specific causal effect and you want to minimize the confounding and selection bias that might operate. So this is the sticking point. The next issue is that it means that in a predictive model, the coefficients are uninterpretable. The specific focus in a causal inference model is to make coefficients interpretable, or the specific one for that specific variable of interest. And of course, we know that predictive modeling can be automated, but I don't think it's yet possible with causal inference because we have to bring that external information to bear in our modeling. So if we ask, where's the confusion? Well, it's because we use the same methodology for both, but obviously very different philosophies about how to deploy them. It's not helped by sloppy language. This is a very short but entertaining article that discusses the use of risk factors, and the term basically manages to help conflate the confusion. There's also some taboo in terms of claiming we can do any causal inference from observational data. But my point is that methods have come a long way and perhaps people aren't aware of what's possible, or more to the point of how much things could be done wrongly that we can now understand and should therefore avoid. So the way I would recommend that we try and make sense in an observational setting is to encode the data generating mechanism in some way. And the best way to do that is through what's called a directed acyclic graph. It enables us to specify our research question very explicitly using the external knowledge and theory that we have of the data generating process. So DAGs are nothing too sophisticated, they're non-parametric, but they are underpinned with robust mathematical understanding, so they're useful. They are just a set of variables that are depicted as nodes with relationships at arcs, and they're directed. There's no cycle, so hence the acyclic nature. It is possible to have feedback between two variables, however, because you can record them longitudinally in repeated measures. So it does deal with feedback situations, but that's more a complex situation than I'm illustrating here for simplicity. So the point is to use this type of encoded information that you have in the DAG to focus on what's known as a focal relationship. That's the exposure outcome relationship you're interested in. So if you're seeking the total causal effect of C on F, for instance, then it starts to define the role of other variables that would inform how you go about modeling this total causal effect. So initially, any variables that cause both the exposure and the outcome are confounders. That's the formal definition. And they introduce spurious statistical association unless you adjust for them or condition on them in some way. So you would model those variables. But you would choose not to include variables that are on the causal path, mediators, because they would affect the estimate that it's no longer the total causal effect that you're estimating. So you wouldn't wish to adjust for those. There is also this concept of competing exposures, which is just a source of heterogeneity. And that could be viewed, for example, as the different instruments used to record the data, or different settings, different centers, different countries, different regions. So it's just heterogeneity in the actual data. So the point is that you should condition on confounders. You should not condition on mediators, and you have the option to improve precision by adjusting for these competing exposures that just introduce heterogeneity. Now, the implication of this has been well understood for over 2 decades, maybe 3 decades or more, easily, but perhaps not being widely shared. So this paper actually made this specific point in a high impact journal that if you have a typical paper, the first table is a summary of the data, and the second table is just a model, a single model of the data that is the study focus. Now, if you're interested in the exposure outcome relationship of just one exposure, that might be sufficient. But the point is that focal relationship should be informed by your DAG, and it means that none of the confounders that are included in that model can be interpreted. So you can't interpret the whole model or all the coefficients in the model. I emphasize that we've known this, well, for 2 to 3 decades, but it's been prominently pushed, at least for the last 10 years, and yet we still see behaviors that ignore this. Often in an urgent situation, like when we had the pandemic, people want answers very quickly. And this particular study appeared in Nature, examined factors associated with COVID-19 related death. They seek understanding of what leads to the death, but that's not clear if that's going to be purely to predict or to determine. It seems more deterministic causal understanding. And yet they go on to effectively do a massive association study. It's a prediction model, though some adjustment for confounding may have been suggested, leading to the potential causal meaning interpretation, but it's just a massive association study. And as we know, if you do include mediators, you can get sign reversal. And it was clear in this study that the smoking, for example, was protective of COVID death, which is nonsense, but it was understandable because it adjusted for mediators on the causal path between smoking and the outcome. So that isn't a causal model to inform any policy decision. Nevertheless, the French government used the coefficients from this model for their equivalent to a furlough scheme to protect individuals who were at risk. So that would mean that all non-smokers would have the opportunity of being protected from the workforce of risk of COVID, which is nonsense. Thankfully, a causal inference expert took the government to court and it was thrown out. So it didn't actually do any harm in this situation. But I think it's an illustrative example that begs the question, what data and analytics are typically available for effective public health emergency response? What do you go about doing? Is it a causal question or a prediction that you're interested in? So to summarize, the point is that prediction is about the outcome only. It's using the covariates in a predictive capacity, but it's the outcome that's important. And the joint information and contribution of the predictors don't have any meaning. There's no causal interpretation from their coefficients. And as I've said, in many situations, not only are they biased, you can have sign reversal. It's quite common. In causal inference, on the other hand, you need external knowledge, the data generating mechanism. You can then code that, and that then informs how you analyze specific causal questions. And it does mean, of course, that you'd have to explore separate models for every single exposure of interest. And you cannot, in those models, interpret coefficients of confounders. My point is that confusing the two can lead to quite harmful interventions if you're acting on a coefficient that's sign reverse, for example. Thank you.
Thank you, Mark. That was really enlightening and probably made a few people's brains hurt. Any technical questions before we move on to the next speaker? We will have 30 minutes or so for discussion, but just any clarifying questions from the audience now? Please raise your hands. Okay, I don't see anything just yet. Thanks, Mark. We'll go on to Isabel Moncrieff, who is going to be speaking to us about correlation versus causation. Izzy is from the CAI unit working with UNICEF in DRC. and is going to be speaking with us about when is evidence good enough for action. Izzy, over to you.
Perfect, thank you very much. I'm going to keep my video off just because the internet connection here is a bit ropey. But thanks again for the opportunity to present. So very different presentation, but hopefully still insightful. So yeah, I mean the CAI, we're an operational research unit. I work with Simone, and so we conduct IOA and integrated outbreak analytics around public health emergencies. I'm based in the DRC, as Ruby said. So I'm going to present a couple of examples just to emphasize the fact that when we conduct, hang on one second, when applying the IOA approach, we talk about correlation, we don't talk about causation. There's a tendency to look at a data set. For example, here we've got graphs of DHS2 data, so the government health structure data. And you can look at a trend and say, oh, well, that must be because of this event that you might know happened at a particular time. But we can never say that only one thing caused something that we see. It's not possible to say with certainty that an event or that the trend that we see can be a result of this particular action or indeed a population behavior. So this is an example from Kongolo, which is a health zone in Tanganyika province in DRC. On the graph on the left is showing the home deliveries, so the women who deliver at home, comparing, so the line at the top, you have Kongolo in Tanganyika, and the two lines at the bottom are two other health zones that we also conducted this analyses in, so in a different province. On the right-hand side, we have a graph for VPO0, so the first polio vaccination. Also looking at comparing the three health zones, and the line for Kongolo health zone is at the bottom. So we can look at these two graphs and we can say, okay, well, perhaps there is a correlation. Perhaps there's a correlation between the home deliveries and the low vaccination rate. But we can't say with certainty that one caused the other. But the point to make here is this data enough? So can we say that by looking at these graphs and having this correlation, is this enough to encourage us to take action, or is it sufficient evidence for response actors to then respond to the particular problem based on this data? So as with IOA, IOA gives us a contextualized image of the reality, so to allow us to really create a contextualized response based on what's available to us. So, and this is something that we wouldn't get from just using one data source alone. So this is I'm sure everyone, well, some of you may have seen this little image on the right hand side. It's the sort of wheel of IOA, which shows the fact that it's an integration of different data sources into analyses to provide this holistic image of the context. And so, as with IOA, we can't just use one data source. But the question is what and how much evidence do we need in order to inform a response and inform a very targeted response? So is this DHS2 graph, for example, showing which shows a possible association, is that really enough? So, I mean, we would argue no through IOA, but it's because it's critical. What's vital is to find the nuanced explanation of the reasons. And these are things that would be able to inform decisions that speak to the micro reasons and not just the raw association at the macro level. So in this case, you have home deliveries where's the risk that women will not vaccinate their children, so they don't receive the sensitization or the community engagement from the midwives in the health structures. They also lack the opportunity for first vaccination if their child is born at the hospital. But that's not really enough. When we need to ask, okay, well, why? What are the reasons why the women are not attending the hospitals? Through qualitative research, we established that and household surveys that women are not attending the health centres often because of the money, but actually delivering in health structures is cheaper than delivering in prayer houses. Or also what women tend to do in Congolo is to have, if they're not at a health structure, they will there are community midwives who they pay more than in the hospitals. There's also an influence of religious leaders, so certain religious groups actively dissuade mothers from delivering at health structures. But the principal reason that we identified, so through healthcare workers and the women, was actually related to WASH, and so the WASH conditions at the health facilities, and particularly for the maternity. So there's the lack of latrines, or latrines that have no privacy, or they're insecure with no locks, and so women are there for possibly for several days having to use neighbours' latrines. So in any case, all this information collectively can support evidence use at multiple levels. So this can be community, so community level based on what's available and possible for them at that time, without requiring extra support from partners or from the Ministry of Health. Then also at provincial and a national level, but these, I mean, for example, they could be the community, it could be healthcare workers or community health workers conducting community engagement, sensitization with religious leaders, communities around the importance of vaccination and the benefits of delivering at hospitals. But then a step up from that could be, for example, with something that we did successfully do using this evidence, was with UNICEF, so the WASH section with UNICEF, presenting the evidence to them, and then we've now managed to, or they have adapted their strategy to support polio vaccination, including activities to rehabilitate WASH facilities in maternities for health structures. So that's one example. The other one I wanted just to raise was related to the endemic of cholera and sexual violence. So this is an example from North Kivu, from Nyiragongo. So using IOA, we're integrating contextual information relating to events. So for the two graphs here, I've noted just the recent waves of population displacement. So there are clearly, well, evidently many more different events, but just two here that seem to correspond or correlate with things that we see in the data. So 300,000 IDPs are now in very large and very unstructured camps in this particular health zone. So the graph on the left is looking at DHS2 data again, and it's cases of sexual violence by year. So the blue line is 2022, and on the far left you see one purple dot, which is the last possible data point we have for January in this year, which as you see the number of cases is considerably higher than previous years. And the right hand side is the current cholera outbreak. So just some contextual information regarding the situation here. So you have, regarding cholera, we've got 59% of cases of cholera are in women in the camps. So that's what have been reported so far. There are demographic estimates of more women in the men than the camps, so that could also just be because there are more women. But then we have situation related to the roles of women, and so the risk of transmission and their role in prevention. The links with sexual violence, again, I'm not saying one is the cause of the other, but the fact that we're presenting the data and the possible correlation here is what we need to raise to see if there's a way of informing responses to address both. Because what we tend to have is the cholera is addressed, but not the sexual violence. So in this case, camps have very few toilets. You've got women who are at risk of sexual violence. They have to walk further away from their shelters and from their camp to find privacy and space. And then as a result, you've got women to protect themselves from sexual violence, women who are building makeshift latrines very next to their houses for themselves and their daughters, which then exacerbates the risk of cholera transmission. So we can say here there's a sort of a way up between safe sanitation and safe access to sanitation. You've either got the risk of cholera or the risk of sexual violence, and but the main point to raise is, as I said before, it's that there's a tendency to there's a tendency to act on the cholera spikes, but not on sexual violence. So there are countless responses or programs for cholera prevention that are currently underway in Nyiragongo, even though the number of cases is sort of uncontrollable. But at least there are methods, there are activities and interventions underway to address cholera, but the sexual violence seems to be being ignored. And so the question is the evidence that's being presented, is the analysis that's being conducted so far, is it sufficient for cholera and sexual violence? Is there different kind of evidence needed for sexual violence in order to encourage responses, or is there a need for more evidence? So then the key question then is when is evidence good enough? So is evidence good enough for cholera but not good enough for sexual violence? How much do we need in order to, or what quality do we need to have of the analysis in order to be satisfied with the picture that we have? So one way of looking at it could be looking at the different contexts. So we say it might depend on the context. So for acute public health emergencies, so outbreaks such as cholera in this case, or displacement crises, you could argue that it's a matter of life and death if action's not taken quickly. One case of measles in an unpopulated, unvaccinated population or a displaced population could lead to a public health emergency, and it's not worth the risk. So take action soon. But in these cases, it's almost as if we would tolerate a rougher image, not quite such a detailed image, because of this need really to act immediately, but also in contexts such as outbreaks and with IDPs, there's often a sort of already a known or standardized response package, and so the needs are already are often considered obvious. The other side of that would be looking at chronic public health emergencies, so more like malnutrition, GBV. We could also look at endemic diseases, where you could say we would have more time which should be used in order to make sure that the response is of high quality, you have sufficient analysis, but also because the response is one that will need to be sustained. But with the more time, I mean, this is a question really that would be really interesting to discuss. Does having more time mean that more data is needed? Do we need more data for chronic health emergencies than acute? Or is it a case of needing more evidence in order to justify the types of responses? Are they responses that normally would cost more money, and so that organizations, Ministry of Health, would require more evidence to justify a response? I don't know, but it's sort of interesting to consider the two options or the two contexts in that way. I've run slightly over time, even with my 3 slides, but thank you very much and welcome any questions and discussion.
Great, thank you so much, Izzy. Yeah, really thought-provoking stuff. Let me just ask if there's any clarifying questions for Izzy before we delve into, I think it might be a nice idea to start off with her questions to the audience. So first, any clarifying questions? I don't see any hands. So does anyone want to comment on Izzy's thought-provoking questions at the end of her slide? Izzy, I don't know if you want to share your slide again.
Yeah, give me 1 second. Sorry, that would have.
So basically, to respond to sexual violence, what do we need? Do we need more evidence? Do we need more time? How can we support or justify programs against sexual support programs against sexual violence? I think Raisa has put something in the chat box, but is there anyone that would like to kick off? Otherwise, I'll. Or Raisa, would you like to speak to your comments in the box?
Hi, yes, I could, but I completely agree with the presenter, and I'm just wondering, but maybe that's only for that specific example. We do know sexual violence is happening because of poor sanitation. In general, there's so many evidence out there already. So when do we draw the line, basically? Because and that's not just about when you have the cholera outbreak, but in general when we do responses in WASH. So can we build on the existing knowledge that is already out there and kind of frame it around that, or what else do we need?
Exactly, it's a very good point. Would anyone like to respond to that? I saw somebody's hand was up, but I think they've put it down now.
Rahini still has a hand up.
Okay, I think it's my screen isn't showing. Izzy, if you could stop sharing your screen, actually, I think it's not in presenter mode anyway. Rahina, yeah, sorry, thanks.
Hi, thank you. Let me share my video a little bit. Hi, thank you, everyone. I'm Rohini Pandey. I'm a demographer and gender specialist at the World Bank, and also starting to work with Simone in DRC. And this is my first IOA meeting, so I'm very happy to join you. Great presentation. So the question I have for Izzy, that was really interesting. I've actually worked on research to policy on sexual violence in Pakistan. And I guess my view, in a sense, is that as researchers, purely on a research basis, we are limited in what we can do based on data for questions that are so deeply embedded as sexual violence. It's not just related to cholera, it's related to pretty much every facet of life. And so I think another key question to ask would be, how can we as researchers recognize that for questions that deal with deep-seated gender or other social norms, how can we best partner with activists or advocates or communications people to use the evidence that we have to really try and open up the space for the conversation, at least, where the conversation goes beyond the hard evidence of how much there is to where it's coming from and what can policymakers do about it. So I don't think it's a question of just evidence. I think actually in places like DRC, we have a lot of evidence. It's a question of who do we collaborate with to open the space for policymakers and other actors to act on these issues. Thank you.
Thanks, Rohini. Yeah, it's you can build up an evidence base, and it's really what is that important trigger to get action. Izzy, I don't know if you want to come back and comment on that point. Otherwise, I can go to the next question.
Yeah, sorry, I actually completely lost connection for most of the I lost connection for most of the question. I wondered if you could summarize it or skip ahead, but sorry about that.
No, I think Rohini was basically saying that we can have quite a lot of evidence and particularly in places like DRC, but who do we need to partner with, or what is that trigger that's needed in order to achieve policy change? Which I think was basically your question as well, wasn't it, Izzy? I think we might have lost Izzy again.
Yeah, yeah, I mean, I think for our operational next step for. Hello.
Hi, yeah, we can hear you.
Hello. Hi. Okay, good. Sorry. Yeah. So the way of so the question would be how to we have the evidence, how do we get it used? So process as well. So ensuring the sharing of the evidence. It's not enough just to conduct analyses, send someone an email with a report and say, fingers crossed, we hope you use it. But it's how can we work with actors at different levels? So, but starting at community level, and within their means, within their capacity, what can they do with the information that we present? It might not be we present a DHIS2 graph with collective IOA analyses to people at community level, but present to them the key results, the main themes of the analysis, discuss with them, co-develop actions to address the issues within their limitations. And then the next stage is more thorough, because you will also bring the analyses to the, for example, the provincial level actors, or actors at a slightly higher level, where we would also share the recommendations and the suggestions provided by the community. So we would kind of see it as a step-by-step process, where at each level we're presenting more and more slightly more thorough analyses, but to allow the evidence to be more targeted to the level of the actor. But I think just to respond more concisely to the question, I think it's more about just assuring the interactive sharing, ensuring from the beginning that there is engagement with the analysis, and not keeping it a top-down approach, which there is a tendency to do if we're in sort of in more talking about research. Yeah, that would be my response.
Yeah, thanks, Izzy. I think there have been a couple of questions or comments in the chat box. Rachel asks what has received the strongest attention from various actors in terms of sexual violence data, and do we have any examples of where this message is heard?
If I can just give an example from this context, in the areas of the DRC where we work, sexual violence is treated almost as exclusively a protection issue, without linking in the different sectors that are all it's a multi-sectoral approach, but it's considered a protection issue, which means that if we have health actors, often they will. I'm not talking about actors like MSF or medical organizations that do provide medical support for sexual violence, but looking at prevention of sexual violence, it's considered more of a protection and safeguarding issue. And so for this particular response, we're not aware of if we're talking about this endemic with cholera, we're not aware of specific interventions and activities that are being conducted to address the sexual violence aspect of the problem, but rather it's cholera. But I don't know if there are some other examples from other contexts that people have, because as was mentioned earlier, it's not a new association, you know.
Yeah, exactly. Thank you, Izzy. Mark has his hand up.
Yeah, I just wanted to put it in context in relation to what I spoke about, which is that I think what you've demonstrated there is very powerful use initially of the data description stages of visualization of the data. I also think that a lot of the research that has provided the evidence is not within that data, it's actually external to it. And so that's the external knowledge that you've effectively encoded in your head, as it were, to triangulate what you believe is happening, but you don't need to know all the causes. If you've got a correlation that is robust, it's powerful at predicting when there's a need to address these unfortunate challenges. So I think that it's all about, which you did say, context, basically. It's all about context as to whether you just look at data from a descriptive point of view, whether you want to use it from a predictive point of view. I think going in and asking the questions and doing qualitative research to understand causal external knowledge, as it were, that informs your data is a very powerful and necessary tool. So I'll just linking it to what I spoke about.
That's great, Mark, because actually I was going to ask you what your thoughts were on this particular type of analysis, and whether your more stringent approach actually makes you nervous when you're watching some of the analysis that we might perform in the field. But I did. No. Oh, okay, perfect. And that's encouraging. I did have a question for you though, Mark, unless there are any other hands up. But one of the first things that we're asked often by ministries of health when there is an outbreak is to perform forecasting or prediction modeling. Where is this outbreak going? How many people are going to be affected? How many people are going to die? What can we expect? And we often have to push back on that. But is there anything that predictive modeling...
May I ask why you push back on that?
Well, we don't often have the capacity, but often the data isn't good enough quality, and we don't often feel that forecasting is helpful. We actually need to respond. We already know what's going to happen in many of these outbreaks, cholera outbreaks, where we've been responding for years. We just need to get on and do it. But one of my questions was going to be, is there anything that prediction modeling can do better to account for causality?
Definitely. I think that one of the processes that I emphasize that is favored for prediction is the automation. And of course, a lot of machine learning and AI is black box automated prediction. There's actually a lot of power, however, in understanding the causal structure or the data generating structure, like from drawing a DAG, even if you're doing a prediction model, because if you find that there are some things which you believe to be causally related to the outcome, then that structurally that's going to be true across different data sets. So if you have something that's not causally related, but correlated to perhaps some measured causes or other causes that are measured with less precision, then the automated prediction tools will select the non-causal predictor because it's trying to find the optimal or favorable prediction in the training set. But of course, you should always impose a degree of parsimony. You actually have to downgrade the prediction model to not overfit within the data set. And if you therefore selected causal predictors, even though it made your model slightly less brilliant on the training data, it's more likely to be better overall in other data sets. In other words, it will predict out of sample far more accurately. So causal knowledge in prediction is very, very useful.
Thank you. Yang Liu has her hand up.
Hi, thank you. Quick question for Mark as well. Really great and clear presentation. I'm just kind of wondering for DAG specifically, for example, a lot of things in practice might not be perfectly fitting in that framework. So for example, there are climate and environmental indicators, factors that are essentially just kind of becoming a big circle because it's like self-reinforcing processes, or there are like links that we would like to account for, but the evidence base might not be at the point where we would like it to be. So for example, we know that smoking leads to cancer, but a lot of the links are not this clear cut. So I think just in terms of how do you, is there a way to account for confidence that you have in these like external information that you're going to incorporate when you are hoping to develop more of like a causal inference / like analytical model? So I think it's a little bit of a two question. So like, first of all, what are you going to do if nature, the mechanism of something is just not acyclic? And the second one is when you have different level of confidence between these links, what are you going to do? Thank you.
So, well, the first one is very easy because nature isn't acyclic in the sense that if you incorporate time, everything's, it is naturally acyclic because, so did I get that the right way around? Yeah. So basically, if you incorporate time and you take repeat measures of your mechanisms, if there's a feedback loop that's for rolling forward in time, and in the DAG terms, you would actually have repeated measures of that. So it's not, your DAGs can be used in situations where you have feedback mechanisms or cyclical processes taking place. It's just that you have to incorporate time, which makes it a more complicated DAG, but there are techniques and methods that deal with time varying exposures, time varying outcomes, and time varying confounders. They're much more sophisticated. Obviously, I can't cover that in 10 minutes, but that's done, right? So there's no problem with the acyclic nature. I think the other one is very interesting though, because at the end of the day, and I'm not just saying it to be to try and pluck out the major quotes, but you know, all models are wrong. We know that, some are more useful. Now, the thing is that you're never trying to necessarily model the exact mechanistic processes, you know, down to the nitty-gritty of each mechanistic cellular process, say like with cancer. We know that's a complicated process. So I'm not suggesting that DAGs are used, they can be used for deterministic processes like that. You can actually try and populate all of the elements of the cascade of events that lead to a specific outcome. But DAGs are useful in terms of drawing broad inferences around what the collection of events could be in relation to other events. And the idea of confounding, I think, is pretty well reasonably understood by most people. I think the problem of trying to adjust for what's called confounding, but isn't true confounding, like mediator activities, messes things up considerably. So I would say that whilst DAGs are imperfect in the sense that they only encode very high level assumptions and may not be capable of or easily being extended to determine truly at the molecular level mechanistic processes, the point is it nevertheless is a statement of your assumptions and of what follows what in terms of temporality, cause and effect, and your assumptions of what you've learned from other studies. So you bring that in. It may be imperfect, but the point being that the analyses you conduct are conditional on those assumptions, and the DAG is explicit about those assumptions. You could change your DAG and change your analyses, and your interpretation will be then conditional on your revised DAG. And such sensitivity analyses or uncertainty about missing variables are also well advised as natural processes. So you don't take the one DAG as if it's the answer, the panacea, and the one model, or the several models for the different exposures. You have to explore around. But the point being that beforehand, what we were doing was just throwing everything in. It's a prediction model, and it doesn't explicitly help understand the assumptions. And I'm pointing out that as a result, it can often be extremely misleading. I don't know if that's answered your question.
Yeah, it did. Thank you so much. Thank you.
Great. Any more questions? I wanted to ask what might be a silly question to Mark, but if you have to do lots of DAGs for all the potential factors that could be causing causality, doesn't that mean that actually with all these multiple association analyses, you could end up getting a spurious one that isn't actually causal at all? And then you have to account for that in your multiple association analyses.
You draw a DAG for the focal relationship of interest, but if you're obviously interested in several factors, then in a sense, you do a scoping exercise of what's informative or influential of the exposure outcome relationship for every exposure you're interested in. You therefore try and draw that landscape in a DAG before you collect data. And it's likely that once you have to be honest with yourself, what matters, and you have to put that in the DAG. But you may not have data for everything that's in the DAG then. And of course, the DAG is a top level holistic view of things, and you have to interpret it accordingly. But I think if you take the temporal order of events and the best known structures of the mechanisms that other studies or other contexts have informed you to believe, then the causal relationships you get will be based on those assumptions. They may still be biased if you've got unmodeled confounding and you're missing confounders in your modeling, but it's also feasible to simulate those situations and then do proper quantitative bias analysis. So instead of at the end of it, as we often do in papers, say, but we were missing, important confounders, or we didn't measure this properly, or that wasn't available, so it's probably still confounded. You can ask the question, well, how strongly would it matter if I had that variable to how it would change the estimate? So there's no panacea. There's no, there's no free lunch. You have to make the assumptions, and sharing those through a DAG is actually very helpful for being critiqued and having the discussions as to whether the DAG is appropriate. But also it will illuminate where there are weaknesses, and you can quantify what those weaknesses are. So it's not a silver bullet. It's just that it's actually a more concrete way to get at least the right sign and hopefully closer to the true causal effect estimate that you're after. I don't know, again, if that's answered your question.
No, it has. That's great. Thank you very much. I did have one more question, unless there's another question in the audience, and it's Mark again, I'm sorry. But I just looking at the IOA approach and bringing all these very different data sets together, some quantitative, some qualitative, some good quality, some not, et cetera, and looking at the types of analyses that Izzy was presenting, do you think that there's we should be introducing more robustness in this kind of analysis? And if so, was there something that struck you already in some of the analyses that we've shown?
No, I think that I'm certainly not about to try and criticize the attempts made to draw causal inferences in the way that's been described, because, as I say, I think what you've got there is a process where the triangulation and the external knowledge and understanding is occurring in the minds of the researchers using descriptive data that is very informative. So I don't think that they are, I'm not trying to put them down by saying they're not analyses. I think the investigations and relationships are understood to be causal, in part by things known and in part by some things unknown. I think the robustness of the analyses stopped at that point in terms of proving it from an analytical point of view, but became very convincing from a social science point of view of actually understanding that when you triangulate all of the known evidence, you are saying, oh, this signature is likely largely as a consequence of these causes. So I think that the process that you take, if you can't bring the data sets together in a linked fashion to answer those type of difficult questions, then the process that has been undertaken makes perfect sense.
Fantastic. Thanks for that, Mark. And we're going to close the session a couple of minutes ahead of schedule. I just wanted to let you know that there will be no session on the 7th of April because it's a holiday in many parts of the world. And we will kick off the next session on the 21st of April with 2 fantastic speakers speaking about sexual and reproductive health. So looking forward to seeing you all then. Take care. And thank you, Mark and Izzy, for some fantastic presentations today. Thank you.
Thank you for having us. Thanks. Cheers.
Thank you very much.
Bye-bye, folks.